Thank you, Team EICON. Thank you, Chairperson. Time start, please. 15, yeah. Actually, that is not the time bar. The bar is that at 8:30, the bar will be lifted from the bar and there will be no bar. So 8:30 is the bar, not that 15 minutes. Now you will be surprised. I am confused because this session is confusing. Two eminent surgeon followed by a subject, are we focusing on the right thread for ASCVD? But you know, the two surgical subject had got nothing to do with ASCVD. They are non-ASCVD surgeries because of this third talk, because there will be no ASCVD if we treat our patients properly. So that is the preamble of my talk, and you will be confused by the here also. They have got nothing to do with ASCVD at the moment, but you know, there is a ground has to be prepared before sowing the seed. So you will understand that later on. So the first thing is that I start with a case. You have got a XYZ or ABC who came with chest pain and shortness of breath as about 60 years, quite fat. ECG shows STEMI, CT scan, significant disseminated disease in LAD and RC, like we showed our case today from Amri Dhakuria, similar kind of case. With diabetes, control on MET, hypertension on ramipril, lipid profile 1 year back, 160 LDL, on atorvastatin 40. He could not go up to 80. And now it is 85 on 40 milligram. Fine. Is it fine? Now we have to assess why and how we estimate the risk. How do we personalize the risk? Like Denton Cooley said, no? Yes. We have to personalize the case. So I am also here to say the same thing. And how do we document or reclassify ASCVD? Now you see the dyslipidemia, most important risk factor that Salim Yusuf said about a few years ago, that of the 9 things, if you can reverse, you will stop 9 heart attacks out of 10. And top of the chart was the ApoB-ApoA ratio, or LDL cholesterol. Very much down, number 7 is diabetes. So don't say who about diabetes. It is LDL cholesterol who is top, and the lower caste is number and diabetes, hypertension. They are much lower. Much higher is lipid, and then smoking, then alcohol, obesity, etc. Now we know that LDL is the primary driver of the lipids. LDL is the primary driver for ASCVD, and we know that by various primordial disease, primary studies, primary prevention, secondary prevention, tertiary prevention. We know that LDL is the main villain, and there are other sub-villains or associate villain because it's a mafia gang. One person is the mafia leader, others are the gang members. Now, LDL is the causal and modifiable risk factor for ASCVD. 1 millimole reduction is 40 milligram or 39 point something. That reduces ASCVD in 1 year by 10%. By 2 years by 16%, by 3 years by 20%. So control 40 milligram LDL. It's easy to say. 1 millimole sounds very nice. 1 millimole control, 1. But 40 milligram control is not so easy. LDL 40 milligram is not so easy. It's 40, not 1 millimole. But if you can do it, you will achieve all these kind of clinical benefits. Now, Indian real world study showed majority of ACS patients are not in their LDL goals. Majority when they come into your, pop into your casualty department, there are 575 patients published in 23. Just this year in February, it was in poster from Chandigarh. 80% were not on target goal. Whether they were known case, whether treated or not, whatever it is, the fact is that when they are coming in, 4 out of 5 were not in their LDL goal. Almost everybody were initiated on high intensity statin. 1/4 of patient underwent dose modification. Major reason was perceived improvement in lipid profile. This is very, very interesting, and I would say that is the most important line, that we cardiologists, physicians, general practitioners, orthopedicians, eye specialists, we all think, though LDL is getting too low, reduce the statin, otherwise the patient will commit suicide or have cataract or have cancer or some other extraneous disease like coronavirus. So this is very important mindset, that if your LDL falls like Niagara, enjoy the fall. Take a click or video clip of that LDL is down there. Don't reduce the dose and stop the Niagara fall. That is the only thing take home, if it's any take home from my talk today. The Indian impact on cardiovascular disease is atherogenic potential. Atherogenic potential and vascular toxicity of LDL is higher in Indians. So we Indians are particularly with animosity with LDL. LDL is particularly bad for us, because they are small, dense LDL, they are more atherogenic LDL. Okay, thank you. I don't want to miss. FOMO hai na? FOMO kothata shunechis to? Fear of missing out. Multiple clinical trials confirm direct correlation between LDL and coronary heart disease. I told it, you know that you are born with this slide. So nowadays, whenever a doctor is entering the MBBS course, they are given this slide. So they know that. So both magnitude and duration of LDL exposure impact. Now this is a new concept coming particularly from Kaushik Ray's group from UK in the Oxford area, that not only the static 1 point LDL level, but the duration of LDL level. Like smoke here. I smoke 10 cigarettes a day for 10 years and I smoke 5 cigarettes a day for 20 years is the same. So it is number of cigarette into number of days. That is your current health harm today. Similarly, how long you are carrying this LDL burden in your body from the age of 8 or from the age of 80, that makes a difference. If you have first detected LDL high at the age of 80, that is not so bad because you are not expecting much. But if at the 8 years of age, your LDL is 170, then it is a tough time to go ahead. So that is very important, that the duration of LDL burden or LDL time. So here it is very nicely shown that if we can check the LDL at an early age and take measure to reduce the LDL, we can change the curve and have the first event deferred by 10 years or 20 years. This is an emerging concept. That means you must check your LDL. I don't know. We are from India. We are trying to give it at 18 years. We will have a meeting next month only, Indian guideline of dyslipidemia. We are already vetted for 18 years, college entry sort of thing. But maybe if there is a strong family history, maybe the age of 10. Or what do they do in the puncture at the newborn, puncture from the heel puncture to get some blood? They do some tests, the neonatologists know. So why don't you check an LDL in the heel puncture blood and see whether the child is born with a high LDL? Then you can start a little bit of a few granules of atorvastatin into your feeding bottle. Maybe that is a concept, as they said, that today's conjecture may be a reality tomorrow. Dr. Ghosh said that. So that is true. You may give some atorvastatin in your feeding bottle. But ESCA's 2019 guideline recommendation for cardiovascular disease risk estimation. Now the score is very dodgy because they have got two scores even in the small area, land area of Europe. One is from higher Europe, one is for lower Europe. So you know where we Indians stand. We love to think ourselves as higher Europe, but we are perhaps not even lower Europe. We are something else. So score system is not valid for Indians. Maybe QRI score, JBS score, they are a bit closer to Asian Indian population. But there are other things which are not score dependent, which are age, which is cardiovascular disease, diabetes, CKD, multiple target organ damage, and so on. And this is a beautiful slide, one of the most elegant slide I have ever come across in my clinical career, coming from ESC, that what is your target? 40, 55, 70, 100, 160. There are 5 targets. And there was one more line over here, which is missing. Yeah, the LDL goal plus more than 50% reduction. Whichever is higher or whichever is lower. So if it is 200, 50% reduction is 100 and your target is 70. So you take 70. Whichever is lower. Okay. So maybe the baseline is 70, your target is 70, but you have to reduce by 50%. So your target is 35. So whichever is lower. Okay. And then you categorize very high, very high with 2 star, high, moderate, and low. Now this is a bit extrapolation because this is 2A recommendation. Up to this is class 1 recommendation. This is class 2A recommendation. If it is a second event within 2 years, then you have to have 40 milligram. Now, we Indians are very aggressive about it. We say it is 30 milligram in such a situation if there is multiple events or polyvascular atherosclerotic cardiovascular disease. But again, that is a bit debatable. Now, these are the things. And very funnily, severe CKD, EGFR below 30, your target is 55. And you are bad to give atorvastatin, rosuvastatin in high dose if there is CKD. So what will you do? You look for other molecules where the CKD is saved as well as your LDL is below 55. This is a bit paradoxical. Not paradoxical, it's difficult to achieve. So latest European guideline, you see 70, 55, 50, and we have got that lipid association where there are 30 in certain cases. There are some logic behind that. Now LDL lower, we accepted, sooner, we now realize, and longer. Just don't reduce the dose. Please enjoy the fall and perpetuate the fall. Do not withdraw or reduce the dose of statin because of your perverted perception that the LDL is too low. No LDL is too low. That is a perversion. Acute LDL reduction post-ACS, strike early, strike strong from evidence to clinical practice. And you will be happy to know that the trials are going on in Kolkata also. Some of my friends are involved in some of the hospitals. Which category does this patient fall in? So first, whether it is 70, 55 or 40, and whether all these risk factors, as you have already explained. So my case, we'll go back to XYZ or ABC. It's a very high risk of developing another ASCVD, and it has to be below 55, if not 40, if not 30. So at least 55, preferably 40, ideally 30. So at least start with 55 goal. He's 70 on 40 milligram atorvastatin. He cannot go beyond 40 because of toxicity. What if the patient has already undergone PCI? What are the risks with early LDL reduction? Readmission within 30 days. About 15% patients are readmitted within 30 days of discharge. Most of the next episode is not the stent-related category. 1/3 is stent-related area. 2/3 is new area. The other plaques, which were not pacified enough, of course not stented. So within 6 months of PCI, if you see AMI is high, 0 to 7 days post-discharge, but it varies how do you define AMI. Maybe CPK rise if AMI, then almost many people will have AMI. But I think you will debate this figure. We don't experience in our figure that very many patients come back with a second AMI within first week. Heart failure, yes. Heart failure on discharge is very common. And 20% will have a recurrent cardiovascular event during the first year. Some kind of angina, unstable angina, some kind of hospital emergency visit. And there is about 100,000 patients who are hospitalized with acute MI, and the median age was around 74 and almost 2.5 years follow-up. Lower LDL was shown to be better in this ACS patient in Miracle, in A to Z, in Prove It, with Improve It. We know that for a long time. Even in many of the trials, we knew that 30 is better than 40, 20 is better than Jupiter. Jupiter showed incremental benefit even at 20 milligram LDL compared to 30, 30 better than 40, 40 better than 50. But it didn't do anything at that time. You are more concerned with the CRP because the Paul Ritker was the maker of CRP. So we thought the CRP has to be checked in everybody. We lost our focus of LDL because Paul Ritker was the first author. So we knew that, but we didn't take any action because we had no arms in our hand to target that, because you cannot go beyond 80 atorvastatin beyond 40, and with that you cannot achieve 20 LDL. So better not discuss which we cannot achieve. That was the idea, but now we can do it. Now we can do it with so many things. Potent LDL lowering early benefit you see in all those big trials. Cumulative incidence rate by LDL change from index event to the cardiac rehabilitation visit again depends on your cholesterol, and then that is 0.36 millimole reduction. You see 0.36 means around 15, 20. So we know that 20 is better. So as I said, it is to prepare the ground to give one after another ezetimibe, bempedoic acid, the evolocumab, alirocumab, and then if comes inclisiran. So we have got all these shots in the arm now. So why don't we accept the fact that 20 or 30 LDL cholesterol is good and is achievable? We know it was good for last 20 years, but as it was not achievable, we are not discussing it just to avoid our embarrassment to our patient and to the media. Look, we know that it is bad for you have 40 milligram LDL, but sorry, we can't help it. That's why you didn't discuss it, because we feel stupid. But now we feel smart, we look smart, so why don't we act smart? Thank you.